I will now request our next speaker, Dr. Dudani, who's a retina surgeon, who is going to talk to you on how he implants secondary IOL. The retina man is usually the fellow who has landed up with cases where someone has either broken the face, broken the lens, and they send the case across to him that now you fit a secondary implant. So he's now going to demonstrate how to do it. He's one of the foremost retina surgeons in Mumbai, though he looks very disarmingly young and quiet. Very active surgeon. Dr. Dudani, please.
Thank you, sir, for a kind introduction. Sadly, this is a medley of cases how we have tackled, secondary IOL. So, IOL implantation and secondary IOL implantation, I have a few rules. Always expect the unexpected. If you're ready for it, then you'll be managing your complications well. And Murphy's law always applies in these surgeries that if something is going to go wrong, it will go wrong. Even there's a 0.1% probability of that happening. Never blame the cataract or the patient for the problems that you're having. Always learn to blame yourself if you want to learn. In a drop nucleus, always insert the IOL in the sulcus or the lenses. When in doubt, no IOL. In case of nucleus drops, don't fish for chips. Secondary IOL needs a very good anterior vitrectomy and also a good mid-vitrectomy. That's how your IOLs stay well. Past planar approach is the best for a vitrectomy. To do a good vitrectomy, use an infusion cannula or an AC maintainer. And there's a technique of vitreous levitation for IOL drop in mid-vitreous, where you don't have to drop the IOL on the retina and then pick it up. So these are the few choices of AC IOL. Has been a very, it's got a very bad name, but I think it's a very good IOL. If you do a good anterior mid-vitrectomy and do a good PBHI, it's a very excellent lens. Posterior iris claw is a good lens, but never in a vitrectomized eye, because your wound stays open when you're trying to enclave the IOL and hold it, and the eye the cornea just keeps on, collapsing. So in a totally vitrectomized eye, it's an extremely difficult lens to insert. I've learned it the hard way. Flanged IOLs, I'll describe to you a technique of what I use called as a dumbbell IOL. Scleral support IOL. PMMA on the residual capsule is a lifesaver. So go back to your PMMA IOLs if you have a residual lens capsule. A foldable hydrophilic lens, though my anterior segment surgeons will say no, 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 on the capsular rhexis in the sulcus, does work very well and doesn't cause UGH or iris chaffing. And suture supporting in the bag. So this is my first video of, on an open PC, you can put a foldable IOL if you have enough rhexis or a combination of anterior posterior capsular support here. You can dump the IOL on the iris initially and then gradually and gingerly sort of, push one haptic behind and you'll be safe enough. This is another video of inserting a PMMA IOL onto a residual capsule. A PMMA IOL, which used to have the old-time IOLs, which are large IOLs, 12.5 millimeter. They lie very well in the ciliary sulcus, and if you gingerly put it over the residual capsule, you can have any anterior or posterior capsular remnant. You might not necessarily have a complete rhexis also. So when you're doing a vitrectomy in these eyes, please try to preserve as much capsule as possible. It's very precious in these eyes. If you want to avoid these extreme maneuvers of, dumbbelling or doing yamanes. In this, it's better to flex and put the trailing loop rather than dial it, because there's a risk of damaging the zonules further. But if you're carefully dialing like I did in this case, you can manage to put the trailing haptic also over your residual lens capsule. So AC IOLs are my favorite IOLs because they, after I've removed a drop nucleus from the vitreous and I've done a vitrectomy, I've as it is spent 45 minutes for that case, and then you require patients to do another 45 minutes of suture support. So I have over time learned the trick of doing this IOL. Do a very good anterior mid-vitrectomy, deepen your AC, and please keep the haptics always horizontal and never vertical, because when the lids are moving, that's where you get the pain for the patient. If you dial it very carefully, you have to flex the loops and dial it. As you saw, you can't dial it how you dial your posterior chamber lens, and these patients will give you a very rounded pupil, unlike the cat's eye pupil, which you might get more common in patients with posterior iris claw. Please don't forget to do a peripheral buttonhole iridectomy. In these cases, it's mandatory. And I have a follow-up almost 20 years of these patients in my medical college where I'm working, and the eyes are pristine, and we have done a study on the endothelial cells also. So if you have sized your lens properly as per white to white, these lenses do very well. They have honestly undergone a lot of bad name, saying that it causes endothelial cell loss, but it doesn't. If it's a well vitrectomized eye, then the IOL stays very back, because of our incomplete vitrectomies when these lenses don't do well. I specifically wanted to show that PVI, you can do it the old way, or we as retinal surgeons can also use the vitreous cutter nowadays to create an iridectomy in these eyes. Another video of the ACIOL. You could also, constrict the pupil would be better in these patients. When you're inserting the IOL, it gives you a better sort of scaffold to put the lens very well.
Suture assisted 10-0. Dialer. Alignment on the cornea. The डॉलीची सर्जरी होते डोळ्याची होते what is this लिंगायत suture system suture 10-0.
So this is another case which we had. In which I had an opaque IOL. I had a high hopes that I'll get the IOL out without damaging the capsular bag, and I kept a PC IOL, but unfortunately you can see the whole bag came out with this IOL. This is the very few subset of hydrophilic lenses which became totally opaque. So in this patient now you can see that the whole bag with the lens is out. And when you have the bag with the lens, I think you've got to use a little more sturdier forceps, because this capsular bag tends to slip, with your Kelman. So you can also use the tooth forceps in these eyes, because with the bag the whole thing becomes very slippery, This is the iris claw. One sec, sorry. So posterior iris claw is now the flavor of the season. But you can see this is one of the eyes where it's vitrectomized. You can see I've done a 3-port vitrectomy, So when you're holding the lens and the eyeball is fully full of, your fluid in these patients, your eye tends to collapse terribly, unlike when you have a vitreous-filled cavity, because your wound is going to stay open. You have to hold the lens while you're enclaving it, So this makes the whole thing, as you can see, how difficult it becomes in this situation to enclave it, because the eyeball is collapsing constantly, because the fluid is, though your infusion is on, you've got a fish mouth incision which you're holding the lens with, with that large forceps which you have. So you can see the whole eyeball is collapsing. I'm not getting a counter to do it. So I have a rule that in a vitrectomized eye, when I've removed a dropped nucleus from the macula, it's extremely difficult to enclave these patients. And, you can see how floppy the iris is, and you can't enclave it. So it's really a tough ball game. But otherwise, in a quiet case where you've just done an anterior vitrectomy and the whole posterior vitreous is full and your eyeball is formed, it's a beautiful lens to insert, And please enclave very carefully the minimum iris at the base of the root, and don't go to the mid periphery, because then you'll get a proper cat's eye pupil, which looks extremely, annoying. So this is a difficult case because it's a vitrectomized eye. So again, I want to share with you, I think putting foldable IOLs over residual lens capsule is really, so you can see you can see the whole PC is open, so I'm using the dialer across to act as like, prevent my lens from getting injected straight into the vitreous, and I have to remove one more IOL, So keep it there, dump the IOL over the iris, and very gingerly sort of dial either the trailing loop or the leading loop over the residual lens capsule. So this is another technique which I've found is that, sometimes you can dump the leading haptic over the iris, and if you have enough capsule superiorly or temporally, you could trailing haptic first technique is what I feel, is that wherever the lens, the capsule is more, you first put that haptic over the residual lens capsule, and then you could do the leading haptic later. So I call this as the trailing haptic first technique, where you dump the leading haptic over the iris. So I think, iris can be a lifesaver in these patients and gives you time to sort of juggle your haptics over the residual capsule, the residual CCC, because in these eyes the pupil also doesn't dilate fully. You have to, sort of push the iris back with a Kugelens hook and see where the residual capsule is. So here I'm seeing, again I'm using the superior area of the residual capsule which was visible to dial the leading haptic back, to go reverse like. So this was one case I want to share with you also. One of my colleagues had done this iris claw, one of the hooks disenclaved, So then this is it became like a trapdoor IOL. The IOL was just flipping around with one haptic enclave this side, the other side wasn't. So I went with pass plan. I used my cutter to sort of lift it up, as a sort of, as a fulcrum, and I brought the trapdoor IOL up. Then I opened the wound which was already there, then held it with the normal forceps which we had, the old forceps, stabilize it, and then you could, rather than removing the lens or doing something else, you could just one side is enclaved, you could just enclave the other haptic. So this is a trapdoor iris claw reinsertion, because one of the loops had disenclaved. Now you can see how, means in these patients, if you're very over exuberant during enclavation, you're seeing the level of iris damage which I've created there, So I think we have to be very sort of gentle. These irises are very fragile in these patients because they're re-surgery patients, most of them, So this is one case I just did last week. So, this was a drop, my resident dropped the full nucleus. It was grade 5 nucleus. Then he put the lens on the rexes. He said, I'm just going to put the lens. So now I'm stuck with removing this grade 4 nucleus from the pars plana region. And then I suddenly realized my sister didn't have the phaco-fragmentation ready. Then I thought, okay, I've got centurion. I'll remove the sleeve. And I use the naked tip of the centurion as a phaco-fragmenter. But unfortunately, this centurion machine is so sensitive and so emotional, like, I won't say like whom, but so it doesn't work without the sleeve, So it has got many sensors, so unless the sleeve is there, it won't work. Then I thought I'll cut the sleeve ka end and let only the hub remain, and just I'll put the naked thing. But that also didn't work. It requires a full sleeve covering for the phaco to be activated. So I don't have any equipment. The IOL is there. I can't float the lens up. So I went with the full phaco with the sleeve into the vitreous, making a separate opening. I did a 23 gauge vitrectomy. I cleared the vitreous and the nucleus was lying at the macula. So I went with the full, you can see here, with actually the phaco probe with the sleeve. Now if you have the infusion of the phaco also coming, it tends to push the nucleus pieces away, So keep your infusion of your phaco off, because you have your 3-port vitrectomy coming there. So there's a lot of chattering of the nucleus and everything. Then over the time, we managed to remove this grade 5 nucleus. So I just wanted to share this, Centurion phacoemulsification in the vitreous, I called it, yeah. So I think we retina guys can have a lot of problems. Thank you so much for your indulgence. Thank you.
Thank you very much, Dr. Dudani. That was very interesting.